Welcome back to the deep dive. Today we're digging into the Found Exam 2.pdf blueprint you send over. It looks like a great guide to some really core nursing concepts.
It really is a fantastic starting point. It covers, well, quite a range, doesn't it? We've got sterile technique, urinary and bowel elimination, nutrition, skin integrity.
Right. And communication, sleep, older adults, even some math and lab values thrown in.
Exactly. It's pretty comprehensive. So our mission, I guess, is to sort of pull out the most crucial bits, the really interesting nuggets from this blueprint.
Yeah, give you a solid understanding without it feeling like you're just reading a textbook.
Absolutely. And we know you might be coming at this with different levels of technical know-how, so we'll try to keep it clear, engaging,
Yeah.
use the proper terms, but also explain them.
Sounds good. Okay, so where should we start? Maybe something really foundational like sterile technique that seems to pop up everywhere.
Good call. Sterile technique, or you'll hear it called surgical asepsis. It really boils down to one thing: getting rid of all microorganisms.
All of them, not just like most of them.
No, all. Bacteria, viruses, fungi, even the really tough spores. It's about creating an environment that's completely free.
Okay, so in a nurse's day-to-day, when is this level of extreme cleanliness absolutely essential?
Well, think about any time we're going inside the body, essentially. Inserting the urinary catheter is a big one.
Right.
Changing dressings,
Yeah.
especially on surgical sites or, deep wounds. Managing central lines, that's critical.
Okay.
Or even just assisting in surgical procedures. Anywhere there's a risk of introducing infection directly into the body.
So what are the big don'ts? The things nurses are trained to absolutely avoid when they're trying to maintain that sterile field?
Several things. Sudden movements are surprisingly tricky. They
Yeah.
can stir up air currents and, float contaminants onto your field.
Didn't think about that.
Yeah. And obviously, touching anything non-sterile with your sterile gloves or equipment. That's immediate contamination.
Makes sense.
We also have to watch ourselves. Coughing, sneezing, even talking directly over the sterile field is a no-go. Introduces too many microbes.
Okay.
And the classic one: keep your sterile, gloved hands above your waist, or really above your elbows, and always in your line of sight. Don't let them drop down.
Keep them in that sterile zone. Got it. And the guiding principle behind all this?
It's actually pretty simple. Sterile can only touch sterile.
Right.
As long as your sterile item only comes into contact with other sterile items, you're good. The moment it touches anything non-sterile, well, it's contaminated.
And that starts with putting on sterile gloves correctly, I imagine.
Absolutely. That's a specific skill in itself. You have to put them on without your bare hands touching the outside of the glove. It ensures that critical sterile touches sterile from the get-go.
Okay, fundamental stuff. Now, moving on to a really big section here. Chapter 46, urinary elimination. Looks like 18% of the exam. That's significant.
It is, yeah, a major topic. So let's start with the basics. The act of micturition.
Micturition. Fancy word for peeing, right?
Exactly. Urination. It's actually a pretty complex, coordinated process.
Right.
Involves the brain, the bladder muscle itself, and the sphincter muscles that control the flow.
So how does that work, the brain-bladder connection?
Well, as the bladder fills up, it sends signals up the spinal cord to the brain. Several parts of the brain get involved: the cerebral cortex, thalamus, hypothalamus, brainstem.
Wow, okay, a whole team effort up there.
It is. And those brain areas communicate back down through two specific micturition centers in the spinal cord. Initially, the sympathetic system helps the bladder relax and store urine.
So it holds it in?
Right. But then, as it stretches usually around 400 to 600 milliliters in adults, the signals get stronger. That's when you feel that urgency, that need to
Yeah,
go.
400 to 600 milliliters.
Okay. And if the time's right, the brain tells the parasympathetic system to kick in, making the bladder contract and the sphincter relax. If not, the brain can override and tell the sphincter to stay tight.
Fascinating. So what can go wrong? What are the common problems nurses see with this system?
Oh, quite a few. Urinary retention's a big one. The inability to empty the bladder properly. Urine just builds up.
Okay.
UTIs, urinary tract infections, are incredibly common. We usually talk about upper UTIs like kidney infections or lower UTIs affecting the bladder or urethra.
Right.
And an important point here: just finding bacteria in the urine bacteriuria doesn't always mean there's an infection needing treatment. Sometimes bacteria are present without causing symptoms.
Good distinction. Bacteria present doesn't automatically equal infection. What else?
Then there's urinary incontinence,
Sure.
any involuntary loss of urine, And that's not just one thing either.
No.
No, you have urge incontinence, the sudden, intense, gotta go in now W feeling, maybe with leakage.
Okay, the desperate dash.
Kinda, yeah.
No.
Then stress incontinence,
Right.
that's leakage with a physical pressure, like laughing, coughing, sneezing, lifting.
Okay.
And mixed incontinence is just a combination of both urge and stress symptoms. And we should briefly mention autonomic dysreflexia. It's a serious issue, usually for people with spinal cord injuries. The blueprint points to a YouTube link for more detail on that one, as it's quite complex.
Okay, noted. So sometimes the bladder itself isn't the issue, or maybe it has to be removed. The blueprint talks about urinary diversions. What are those?
Right, so if the bladder has to be removed, maybe due to cancer, that's called a cystectomy, or if it's just not functioning, you need a new way for urine to get out of the body. That's a urinary diversion.
Makes sense. And there are different kinds, continent versus incontinent.
Exactly. Continent means the patient has some control over urination. One type is a continent urinary reservoir. They actually create an internal pouch, usually from part of the bowel.
Wow.
Yeah, inside the abdomen. The ureters drain into it, and there's a small opening, a stoma, on the belly. The patient inserts a catheter through the stoma, maybe 4 to 6 times a day, to drain the urine.
So they have to catheterize themselves regularly?
Correct. There's often a valve mechanism, like the ileocecal valve, that helps prevent leakage between catheterizations. Another continent option is an orthotopic neobladder.
Neobladder, like a new bladder.
Pretty much. Again, usually made from bowel tissue, but it's placed where the original bladder was. The idea is they can try to void more naturally through the urethra, often using a straining technique called the Valsalva maneuver.
That sounds closer to normal function.
No,
What about the incontinent ones?
With incontinent diversions, there's a continuous flow of urine the patient can't control. A common one is a ureterostomy or an ileal conduit.
How does that work?
The ureters are connected to a small piece of the ileum, and that piece is brought out as a stoma on the abdomen. Urine just flows out constantly.
So they need a collection bag.
Yes, they have to wear an external pouch over the stoma all the time to collect the urine. That pouch can often be connected to a larger drainage bag, like a Foley bag, especially overnight. There are also nephrostomy tubes. These are tubes inserted directly into the kidney, the renal pelvis, usually if the ureter is blocked. They drain urine directly from the kidney.
And I imagine patient teaching is huge for all of these.
Absolutely critical, especially for nephrostomy tubes, going home, teaching about site care, signs of infection, ensuring it's draining properly. It's vital.
Okay, let's shift to how nurses assess the urinary system, what's involved.
It's really comprehensive. You start with the patient's perspective. What were their concerns? What are their goals? You need to assess their ability to manage their own care, their self-care ability.
Right.
Cultural factors and gender can play a role in how comfortable people are discussing these issues. Health literacy is key, too. Do they understand the information you're giving them?
Good points.
And you always review their history, usual patterns, past problems, other medical conditions, medications. Then you do the nursing history, asking about current symptoms, frequency, urgency, pain, changes.
And a physical assessment, too.
Definitely. Palpating the bladder if you suspect retention, looking closely at the perineal skin, especially if they're incontinent, for any breakdown. It's a holistic look.
In collecting urine samples, are there different ways to do that?
Yes, depends on the test. For a routine urinalysis, usually a clean catch midstream specimen works. They clean the area, start peeing, stop, collect the sample, then finish.
Avoid contamination from the urethra.
Exactly. If you suspect a UTI, you need a culture and sensitivity. That requires a very specific sterile collection technique to identify the bacteria and see which antibiotics work.
Okay.
And if someone has an indwelling catheter, you can collect the sample aseptically from a special port on the tubing.
Got it. And once you have the results, what are you looking for in a urinalysis?
Lots of clues. First, basic intake and output monitoring is fundamental. Normal adult output is roughly 30 millimoles per hour.
Okay, 30 ml/LHR.
Then color. Pale straw to amber is normal. Dark red might be kidney ureter bleeding. Bright red may be bladder urethral. Dark amber could suggest bilirubin, liver issues. Should be transparent when fresh. Cloudy could mean protein, maybe kidney disease, or bacteria and white blood cells if there's an infection.
And an odor. I know urine has a smell.
Right. Normally a faint ammonia smell.
Yeah.
Stronger if concentrated, like with dehydration. A foul odor often points to a UTI. And some foods, like asparagus, famously change the smell.
Yes. What else does the lab look at?
The full report gives you pH, how acidic or alkaline it is. Protein, glucose, ketones normally shouldn't be there in significant amounts.
Presence could mean diabetes or kidney problems.
Could be, yes. Specific gravity tells you how concentrated the urine is, and they check for red blood cells, white blood cells, crystals, all providing information about kidney function and potential problems like stones or infection.
It's amazing what you can learn. The blueprint also mentions diagnostic imaging.
Right. Things like ultrasounds, x-rays, CT scans, MRIs. They give us pictures of the kidneys, ureters, bladder, help identify blockages, stones, tumors, structural issues.
Okay. Now, catheterization, a very common nursing task. What are the main types?
Broadly, internal and external. Internal ones go into the bladder via the urethra. You have straight catheters, single tube, used for one-time emptying, maybe getting a sample, also called intermittent.
Okay.
Then indwelling catheters, or Foleys, they stay in. Usually double lumen, one drains urine, the other inflates a balloon inside the bladder to hold it in place.
That's the balloon.
Some are triple lumen, an extra channel for irrigation or putting medication into the bladder.
And size matters, the French scale.
Yes, French scale measures diameter.
Yeah.
Bigger number, bigger catheter.
Yeah.
Adults typically use 14 to 16 French for indwelling. Kids, much smaller, like 5 or 6 French.
What about external ones?
For males, you have condom catheters or penile sheaths. They fit over the penis, connect to a drainage bag. Non-invasive option for incontinence.
And insertion and removal, those are key skills.
Absolutely. Strict sterile technique for insertion is crucial to prevent infection. Removal is less complex, but still needs care. The YouTube links mentioned are probably good resources for seeing the technique.
Definitely. And speaking of infection, catheter-associated urinary tract infections. Huge focus on prevention.
Massive. CAUTIs are a major healthcare concern. Prevention involves several key things. Maintaining a closed drainage system, catheter, tubing, bag, all connected, sealed.
Keep it closed.
Prevent backflow. Always keep the drainage bag below the level of the bladder. Gravity is your friend.
Bag below bladder. Got it.
Regular perineal hygiene, cleaning around the urethra, at least every 8 hours and after bowel movements. Empty the bag when it's about half full.
Don't let it get too full and back up.
Right. And only use catheters when necessary. Remove them as soon as possible. If long-term, they're usually changed about every 30 days or per policy.
And finally, for urinary, what about patient education? Promoting good bladder health.
Yeah, helping people maintain normal habits. Encourage regular voiding, not holding it for ages. Plenty of fluids to keep urine dilute. Techniques for complete emptying. And teaching signs of a UTI and how to prevent them.
Okay, solid overview of urinary elimination. Let's switch gears to the other side. Chapter 47, bowel elimination, another big section. Common problems here.
Similar themes, actually. You can have retention, like fecal impaction, hardened stool stuck in the rectum.
Ouch.
Yeah. Constipation, infrequent or difficult BMs. And the opposite, diarrhea, frequent, loose, watery stools.
What causes these issues often?
Often it's related to alterations in peristalsis, those muscle contractions moving things along the digestive tract. Aging, diseases, lots of medications can affect motility, leading to constipation, diarrhea, even heartburn.
So how can nurses help patients promote, normal, healthy bowel function?
Lifestyle's huge here. Dietary fiber is key, adds bulk. Good hydration keeps stools soft. Regular physical activity stimulates the gut.
Makes sense. Move your body, move your bowels.
Pretty much. Establishing a routine, trying to go at the same time each day, helps. Proper positioning on the toilet, sometimes elevating the knees slightly, can make it easier.
Like using a squatty potty.
Exactly that principle. Also, advising people not to ignore the urge to go, and limiting highly processed foods, which are often low in fiber.
Good advice. The blueprint mentions NG tubes, nasogastric tubes. Why would someone need one?
Several reasons. Decompression is one, sucking out gas and fluid if there's a blockage or severe distension.
Okay.
Enteral feeding, giving liquid nutrition through the tube if they can't eat normally. Administering medications.
Right.
Gastric lavage, stomach pumping, basically, in cases of poisoning or overdoses. And sometimes for diagnostics, getting a sample of stomach contents, checking pH, looking for bleeding.
Okay. Another diagnostic mentioned is the fecal occult blood test, or guaiac test. What's that for?
That's looking for hidden occult blood in the stool, blood you can't see just by looking.
Why would you do that?
It can be an early sign of bleeding somewhere in the GI tract. Could be from ulcers, polyps, hemorrhoids, inflammatory bowel disease, or even colorectal cancer.
How does it work?
Patient puts small stool samples on special cards treated with guaiac. In the lab, they add a developer solution. If blood's present, it reacts with the guaiac and usually turns blue.
Blue means positive for blood.
Generally, yes. But it's not foolproof. Certain foods like red meat or some meds can cause false positives.
Oh, yeah.
So patients often get specific diet instructions beforehand. And usually they collect samples over a few days to increase accuracy. A positive test means more investigation is needed, like a colonoscopy, to find the source. A negative doesn't absolutely rule out bleeding, though.
Got it. Moving on to ostomies or bowel diversions, what are some complications nurses watch for with the stoma itself?
The stoma site can have issues. Skin irritation around it is common, maybe from the appliance adhesive or stool leakage. Infection is a risk.
Leakage seems like a big problem.
It can be if the appliance doesn't fit right. Stenosis is a narrowing of the stoma opening. Prolapse is when the stoma sticks out too much. Retraction is when it pulls back in.
Oh, wow.
And you can get a peristomal hernia, where the bowel bulges near the stoma. Good stoma care, proper appliance fit, and careful monitoring are key to preventing these.
And patient education for ostomies must be incredibly important, too.
Absolutely essential for managing at home. They need to learn how to clean the stoma, care for the skin, make sure the pouch fits securely to prevent leaks.
Recognizing problems.
Exactly. Recognizing signs of complications like infection or blockage, knowing when to call for help. Dietary adjustments might be needed, depending on the ostomy type, to manage gas or prevent blockages.
And changing the appliance?
Yes, how to empty the pouch, how to change the whole thing. Staying hydrated is important too.
Yeah.
And we can't forget the emotional support. It's a big life change. Connecting them with resources, support groups, ostomy nurses is really helpful.
Definitely. Does the location of the ostomy affect the stool consistency?
Big time. It depends on how much water has been absorbed before the stool exits. Small intestine ostomy, like an ileostomy, output will be liquid.
Because water hasn't been absorbed yet.
Right. Ascending colon, semi-liquid. Transverse colon, more pasty, mushy. Descending colon, usually formed and soft. Sigmoid colon or rectum, pretty much solid stool.
And that makes sense. Is there a chart for that?
Yeah, the Bristol stool chart is great for this. It classifies stool into 7 types, from hard lumps to liquid. Really useful for describing consistency.
Good tool. Lastly, for bowels, medication administration, enemas, suppositories, laxatives.
Right. Enemas are liquids put into the rectum for constipation. Bowel prep, sometimes meds, usually given with the patient in Sims position on their left side.
Suppositories.
Solid meds inserted rectally. They dissolve and get absorbed. Used for constipation, inflammation, sometimes nausea.
And cathartics and laxatives.
Tends to promote bowel movements. Can be oral or rectal. Lots of types. Bulk forming, stimulants, osmotics, stool softeners, lubricants. Used for constipation, bowel prep, or avoiding straining. Different types have different onset times, too.
Okay, covered a lot on elimination. Let's shift to chapter 45. Nutrition, another huge topic. Starting with enteral nutrition feeding via the GI tract. Advantages.
Big advantages if the gut works. It helps maintain the gut's structure and function, which is really important. Reduces the risk of sepsis compared to IV feeding.
Sepsis.
Can minimize the body's stress response to injury or surgery. And studies show it can decrease mortality in some situations. Basically, if the gut works, use it, is the mantra.
So when is it the go-to method?
When someone can't swallow safely, maybe due to stroke or neurological issues or can't take enough by mouth, but their GI tract is still functioning okay. Critically ill patients, head and neck cancer patients, lots of scenarios.
And there are different tubes for this, nasal versus through the skin?
Yep, nasal tubes are temporary, inserted through the nose. NG tube goes to the stomach, ND tube to the duodenum, NJ tube to the jejunum. Those last two are often used if there's a high risk of aspiration, bypassing the stomach.
Okay, NG, ND, NJ. What about the ones through the skin?
Those are percutaneous tubes placed through a stoma in the abdominal wall. Can be done endoscopically, radiologically, or surgically. G tubes go into the stomach, J tubes into the jejunum.
And they can be long-term.
Yes. For short term, they might have a balloon or bumper inside. For long term, often a lower profile button that sits flush with the skin. These are common for home enteral feeding.
Aspiration is a major worry with tube feeding, right? What are the precautions?
Huge concern. Absolutely critical to prevent. Key recommendations include stopping feeds immediately if you suspect aspiration, checking gastric residual volumes, or GRVs, how much is left in the stomach before the next feed.
What's the cutoff for GRVs?
Generally, over 500 millibale is a red flag. Hold the feed, reassess. Even with 350, 500 under millibale, you need to be cautious, maybe use meds to help emptying. Definitely keep the head of the bed elevated 30, 45 degrees.
Head of bed elevation seems key.
It is. For high-risk patients, rest before feeding, position upright, 90 degrees if possible. Maybe work with speech therapy on food consistency if they're also eating orally. Slow feeding, small bites, chin tuck maneuver.
Lots of little things add up.
Definitely. Minimize distractions, check for pocketing food, keep them upright for 30, 60 minutes after eating. Good oral hygiene, have suction ready. It's a whole process.
What makes someone high risk for aspiration, and what are the signs?
Risk factors include difficulty swallowing, dysphagia, history of stroke, GERD, artificial airways, decreased level of consciousness, lying flat, signs, coughing, choking, gagging, difficulty breathing, wet-sounding voice, drop in oxygen saturation.
And if you suspect it happened.
NPO. Assess airway, oxygen, suction if needed. Notify the provider right away. They'll likely want a chest x-ray, maybe a speech consult.
Okay, let's focus on NG tubes specifically. Insution technique.
Patient upright, high Fowler's usually.
Yeah.
Measure tube length,
Mm.
nose to earlobe, then down to the xiphoid process. Lubricate the tip. Insert gently through the nostril, aiming down and back. Have the patient swallow as it passes the throat. Tilting head forward helps guide it into the esophagus, not the trachea.
And confirming placement. How do you know it's really in the stomach?
Crucial step. Checking pH of aspirated stomach contents is helpful. Should be acidic, less than 5 usually, or the fasting. But listening for air injected into the tube. Not considered reliable anymore.
So what is reliable?
The gold standard for initial placement is an X-ray. You have to visualize the tip in the stomach on the radiograph.
X-ray confirmation. Got it.
After that initial X-ray, you still check placement before each feed or med, often by aspirating and checking pH. Flush the tube regularly to keep it patent. Secure it well. Good nasal and oral care.
What are some general complications of enteral nutrition besides aspiration?
GI issues are common constipation or diarrhea. The tube can get clogged. Electrolyte imbalances can happen. Fluid overload, or the opposite, dehydration if the formula is too concentrated or not enough free water is given.
Okay. Now, what about TPN? Total parenteral nutrition, feeding through an IV. When is that used?
TPN is for when the GI tract isn't working. Severe obstruction, short bowel syndrome, prolonged periods where the bowel just isn't moving, situations where nutrients can't be absorbed through the gut.
Is it different from PPN, parenteral nutrition?
Yes. PPN is usually supplemental, less concentrated, can sometimes go through a large peripheral IV like a PICC, often short-term. TPN is complete nutrition, highly concentrated, and must go through a central venous line.
A central line into a big vein.
Exactly, like the subclavian or internal jugular, with the tip ending in the superior vena cava. The TPN solution is very hyperosmolar, lots of glucose, so it needs that high blood flow to dilute it quickly and avoid damaging smaller veins.
Higher risk, too.
Definitely higher risk than enteral feeding. Central line infections are a major concern. Metabolic issues, fluid imbalances are more common. You need an infusion pump, careful monitoring. The TPN port on line must be clearly labeled and used only for TPN.
Okay. Let's talk diets. Medical nutrition therapy for specific conditions. Examples.
Sure. GERD. Avoid triggers like spicy, fatty, acidic foods. Small, frequent meals. Stay upright after eating.
IBD, inflammatory bowel disease.
High protein, high calorie, often needed. Low fiber during flares might help. Avoid personal trigger foods.
IBS, irritable bowel syndrome.
Low FOD MAP diet often helps. Increase fiber slowly. Avoid gassy foods.
Diabetes.
Carb counting is key. Focus on complex carbs, fiber, balanced protein fat. Limit added sugars. Consistent meal timing.
Heart disease. Cardiovascular.
Heart-healthy patterns like the AAH or Mediterranean. Lots of fruits, veggies, whole grains, healthy fats, low sodium, low saturated trans fats, more omega-3s from fish, flax, walnuts.
Cancer treatment.
Often need high calorie, high protein to prevent weight loss. Manage side effects, small meals for nausea, soft foods for mouth sores, stay hydrated.
HIV/AIDS.
Also need high calorie, high protein to prevent wasting, support the immune system.
Makes sense. And how do nutritional needs change across the lifespan? Briefly.
Big changes. Infants rely on breast milk or formula. Kids need gradual introduction to solids. Adolescents have huge needs: energy, protein, calcium for bones, iron especially for girls starting periods, and boys building muscle.
Adults.
Young little adults need stabilize, but energy requirements often decrease. Obesity risk can increase. Women on birth control might need extra vitamins. Iron and calcium stay important.
Pregnancy and lactation.
Pregnancy needs more calories, protein, calcium. Lactation needs even more calories, about 500 extra per day.
Older adults.
Energy needs decrease further with slower metabolism. Vitamin mineral needs mostly stay the same, but things like appetite, taste, smell, digestion can decline, affecting intake. Risk of food insecurity on fixed incomes is also a concern.
Really important considerations. Okay, shifting again. Chapter 48, skin integrity and wound care. Let's start with open wounds. How do we describe them?
We talk about onset and duration. Acute wounds happen suddenly, trauma, surgical incisions. They usually heal predictably. Chronic wounds are those that fail to heal in a timely way, often due to underlying issues like Poor circulation, chronic inflammation.
And how they heal. Primary, secondary.
Right. Primary intention is when edges are closed, like a sutured incision. Heals fast, minimal scar. Secondary intention is when the wound is left open, maybe tissue loss, contamination.
Yeah.
Heals from the bottom up, takes longer, more scarring.
And tertiary.
That's delayed primary closure. Wound left open initially, maybe due to infection risk, then closed later when it's cleaner.
What can go wrong during healing? Complications.
Hemorrhage, excessive bleeding. If internal, can form a hematoma, a collection of blood under the skin. Infection is a big one. Delays healing.
Dehiscence and evisceration, those sound serious.
They are. Dehiscence is when the wound layer is separate.
Oh.
Evisceration is worse. Organs protrude through the separated wound. That's an emergency. Drainage is normal initially, but changes in amount, color, odor can signal problems.
What factors influence how well someone heals?
Lots of things. Age, older adults heal slower. Nutrition is huge, need protein, vitamins A, C, E, zinc for repair.
Chronic diseases.
Big impact. Diabetes, vascular disease, kidney disease impair healing. Medications like steroids, chemo can interfere. Smoking reduces oxygen delivery. Stress. Even that can slow healing. Good tissue perfusion, blood flow is absolutely essential.
If you suspect infection, you might need a wound culture. How's that done?
Yeah, to identify the bacteria. Usually you clean the wound surface first with sterile saline to remove surface stuff. Then use a sterile swab to collect fluid or tissue from the wound bed, avoiding the edges. Put it in transport medium, send to lab.
Okay. And the nursing process for skin integrity. Assessment, diagnosis.
Assessment is head-to-toe skin inspection, especially high-risk areas like bony prominences. Note any wounds, redness, warmth. Diagnosis uses standard terms like impaired skin integrity or risk for, based on the assessment.
Planning.
Setting SMART goals, specific, measurable, achievable, relevant, time-bound, like wound size will decrease by 1 centimeter in 1 week, or patient will remain free of new pressure injuries.
And implementation is doing the interventions.
Exactly. Wound care, prevention strategies, patient education, collaborating with the team.
Let's focus on pressure injuries. What are they exactly, and where do they usually happen?
They're localized damage to skin and underlying tissue, usually over a bony prominence, sometimes related to a medical device, caused by prolonged pressure, often with shear or friction, cutting off blood flow ischemia.
High-risk spots.
Heels, ankles, sacrum, tailbone, hips, elbows, back of the head. Places where bone is close to skin and bears weight.
What puts someone at risk?
Impaired sensory perception, they can't feel the pressure to shift. Impaired mobility, can't move themselves easily. Altered level of consciousness. Shear, like sliding down in bed. Internal tissues move differently than skin.
Shear versus friction. Can you explain that difference again?
Sure. Shear's internal. Think of the head of the bed up. Body slides down, but skin sticks to sheets. Deep tissues get pulled and damaged. Friction is surface rubbing, like dragging someone across sheets. Damages the outer skin layers. Both bad, but different mechanisms.
Got it. Other risk factors.
Moisture from incontinence, sweat, wound drainage, weakened skin, poor nutrition, dehydration, advanced age. Chronic illnesses affecting circulation, like diabetes.
So who's most at risk?
Immobile patients, those with sensory deficits, altered mental status, incontinence, poor nutrition, chronic circulatory issues. It's often a combination of factors.
Prevention is key then. What strategies work?
Risk assessment first, using something like the Braden scale. Lower score means higher risk. Meticulous skincare inspect, cleanse gently, moisturize. Manage incontinence, keep skin clean and dry.
Repositioning.
Crucial. Turn immobile patients regularly, usually every 2 hours, maybe more often. Use proper lifting techniques to avoid friction shear. Use pressure redistributing surfaces, special mattresses, cushions.
Heel protectors.
Yes, offload pressure from heels, barrier creams for the sacrum, and patient-family education is vital so they understand the risks and how to help prevent injuries.
How are pressure injuries classified or staged, and can they get better in stage?
Staged based on depth of tissue damage,
Yeah.
stage 1 to 4, plus unstageable and deep tissue injury. Importantly, you don't downstage as they heal. A healing stage 3 is always called a healing stage 3, not a stage 2. The tissue doesn't fully regenerate to its original state.
Good point. Okay. Managing wounds. What's the main goal?
To create the best possible environment for healing. Address barriers like infection, excess moisture, or dryness, non-viable tissue.
Debridement comes up a lot. Removing dead tissue.
Exactly. Necrotic tissue harbors bacteria, blocks healing. Several ways to do it. Mechanical, like irrigation, maybe ultrasonic. Autolytic, using body's own enzymes with moisture-retentive dressings. Chemical, using special ointment gels. Sharp surgical, cutting it away.
What about the wound VAC, negative pressure therapy?
And PWT, yeah. Applies suction through a foam dressing in the wound, pulls out excess fluid, reduces swelling, increases blood flow, stimulates new tissue growth. Some systems can also instill fluids, like antiseptics.
Drains like JP or Hemovac. What do nurses monitor?
Amount, color, odor, consistency of drainage. Empty the collection device regularly to maintain suction. Check the insertion site for infection, redness, warmth, swelling. Make sure it's secure.
And cleaning technique for wounds.
General rule.
Yeah.
Least contaminated to most contaminated. For incision, clean along the line, then move outwards. Around a drain, clean near the drain first, then move outwards. Use gentle technique, usually with sterile saline.
Any final safety tips for wound care?
Don't remove the initial surgical dressing without an order. Give pain meds before potentially painful dressing changes. Remember, healed skin is weaker. Consider age-related skin fragility. Assess nutrition status always. Be aware of risks with obesity or meds like steroids. Identify chronic diseases impacting healing.
Excellent. That covers skin integrity well. Now, Chapter 24, communication, foundational skill. SBAR is mentioned. What is it? Why use it?
SBR situation, background assessment recommendation. It's a structured way to communicate critical patient info. Ensures clarity, efficiency, reduces errors. Great for handoffs, calling providers about changes, standardizes communication.
Bedside handoff report. Why is that a good idea?
Conducting the shift report right at the patient's bedside. Allows the oncoming nurse to see the patient, check equipment, ask questions directly. Involves the patient too, which improves safety and engagement. It's really best practice.
How do you adapt communication for patients with impairments? Cognitive, for instance.
Simple sentences, one question at a time. Allow a response time. Listen attentively. Involve family. Pictures or gestures can help.
Hearing impairment.
Check AIDS glasses. Reduce noise. Get attention first. Face them. Mouth visible. No gum. Normal volume, don't shout. Rephrase if needed, maybe sign language interpreter.
Visual impairment.
Check glass contacts. Identify yourself entering, leaving. Normal tone. Avoid relying on gestures. Good lighting, not glaring. Large print, 14-point minimum.
What are some therapeutic communication techniques?
Active listening, sharing observations. You seem.
Yeah.
Empathy, hope, appropriate humor, sharing feelings, touch, if appropriate, focusing, paraphrasing, validation, summarizing, gentle confrontation, relevant questions, building trust, facilitating expression.
And non-therapeutic ones to avoid.
Asking personal questions,
Yeah.
relevant ones, giving opinions, advice, changing subject abruptly, automatic responses, don't worry, false reassurance, sympathy instead of empathy, asking why questions, arguing, approving, disapproving, being defensive, these block communication.
Good list. Okay, Chapter 43, sleep. Circadian rhythms. What are those?
The body's internal 24-hour clock regulates sleep-wake, but also body temp, heart rate, hormones, alertness, mood. Influenced mainly by light-dark, but also temp, social cues, work schedules. Disruption affects sleep and overall health.
Then the sleep cycle itself, NREM and REM.
We cycle through stages. NREM has light to deep sleep, slow-wave sleep. REM is rapid eye movement, sleep, vivid dreaming, brain activity, muscle paralysis. NREM is more for physical restoration, REM for cognitive. A full cycle is about 90 minutes. Repeat 3-5 times a night.
Sleep hygiene. What are the tips for good sleep?
Consistent sleep-wake times, even weekends. Relaxing bedtime routine. Avoid caffeine, consume alcohol, close to bed. Dark, quiet, cool bedroom. No electronics an hour before bed. Blue light effect. Avoid big meals late. Exercise regularly, but not right before bed. Reduce stress.
If someone has sleep problems, what do you ask in an assessment?
Detailed sleep history. Describe the problem: falling asleep, staying asleep, winking early. Usual pattern, recent life events, bedtime routine, environment. Ask about symptoms: daytime sleepiness, snoring, duration, severity, impact on life, nighttime urination, nocturia, fluid intake before bed.
Okay. Chapter 14, older adults. Lots of variation in this group, right?
Absolutely. Huge range in health, function, chronic conditions. Not everyone shows typical disease signs. Important to identify strengths, encourage independence, avoid stereotypes, treat them as individuals.
How to adapt the interview or assessment.
Sit at eye level. Allow time. Reminiscing can build rapport. Use therapeutic touch appropriately. Make sure assistive devices, hearing aids, glasses are working. Use their preferred name. Speak clearly.
Risks in acute care for older adults.
Delirium is a big one. Acute confusion. Dehydration, malnutrition, healthcare-associated infections, urinary incontinence, falls all higher risks in the hospital.
Common physiological changes with aging. Briefly.
Skin less elastic. Decreased cough reflex. Thicker blood vessels, lower cardiac output, slower GI motility, muscle atrophy, bone loss, slower nerve conduction. Sensory changes vision, Hearing, presbycusis, taste, smell, touch often diminish. Immune system less robust. Lower core temp baseline.
Delirium versus dementia versus depression, how to
Yep.
tell them apart.
Key differences. Delirium. Acute onset, fluctuating course, attention disturbance, often due to underlying medical issues. Dementia. Gradual onset, progressive cognitive decline, memory, thinking, usually from brain disease like Alzheimer's. Depression. Persistent sadness, loss of interest, changes in sleep appetite, fatigue, concentration issues. Assessment needs to look at onset course, specific symptoms. They can overlap too.
Altered presentation of illness in older adults, what does that mean?
They often don't show classic signs. Infection might present as confusion, not fever. Heart attack might be fatigue, not chest pain. Nonspecific things like falls, incontinence, appetite loss can signal acute illness. Due to physiological changes, multiple chronic conditions, polypharmacy, need high suspicion, careful assessment.
Health promotion for this group.
Focus on maintaining independence, function, quality of life. Encourage activity, good nutrition, hydration. Health screenings, immunizations. Manage chronic conditions. Address psychosocial needs. Social engagement. Fall prevention is huge.
Polypharmacy using many meds. Concerns.
Very common. Increases risk of adverse effects, drug interactions, errors, non-adherence. Age changes how body handles drugs. Needs careful medication reconciliation, regular review, clear patient education. Box 14.7 in the text likely has more details.
Okay, almost there. Math, basic fluid conversions, and INO.
Need to know basics. 1 ounce is about 30 milliliters, ml. Standard cup is 8 ounces. Coffee cup often around 6 ounces. Intake is all fluids and oral, IV, tube feeds. Output is all fluids out, urine, vomit, liquid stool, drain output. Essential for tracking fluid balance.
And finally, lab values, specifically urinalysis from Chapter 46, key normals and what abnormals might mean.
pH. Normal 4.5, 8.0. Low might mean acidosis. High may be UTI or alkalosis. Protein, normally none and minimal. Presence suggests kidney issues, preeclampsia, infection. Glucose, normally none. Presence suggests diabetes usually. Ketones, normally none. Presence suggests DKA, starvation, vomiting.
Specific gravity.
Normal 1.005, 1.030. Measures concentration. Low might be overhydration, DI. High could be dehydration, DM, SIADH.
Cells.
RBCs, normally none few. Presence hematuria means bleeding somewhere. WBCs, normally none few. Presence, puria, suggests UTI or inflammation, crystals. Can indicate stones, gout, dehydration, metabolic issues, infection. Always interpret in context.
Wow, we really covered a lot there, drawing from that blueprint, everything from sterile feels to the complexities of aging.
Yeah, it's a huge amount of foundational knowledge, isn't it?
Yeah.
But hopefully breaking it down like this, connecting the dots, makes it feel a bit more digestible.
Definitely. The goal was to hit the highlights, pull out those key concepts you really need to grasp. We hope this deep dive gave you some of those aha moments.
It really highlights how interconnected everything is in nursing. Think about hydration, how that single factor impacts urinary function, skin integrity, even cognitive status in older adults. It touches almost everything we discussed.
That's a great point to reflect on how these seemingly separate topics constantly interact in patient care.
Exactly.
Well, thank you so much for joining us for this deep dive. We hope it was helpful.